Over the next few minutes, we will explain the rationale and technique of the pericapsular nerve group block, or PENG block, for hip fracture analgesia. We hope these step-by-step instructions will be of great value for improving your patient care. Regional anesthesia is performed increasingly in patients with hip fracture, providing better analgesia and reducing the use of opioids and opioid-related side effects. Over recent years, an emerging number of publications have helped us understand the sensory innervation of the hip joint and the mechanism of different nerve blocks for hip fractures. Application of this new knowledge has led us to propose this novel technique targeting only the sensory articular branches of the hip. The anterior capsule of the hip is richly innervated by three nerves: the femoral nerve, the obturator nerve, and the accessory obturator nerve. The femoral nerve is a branch of the lumbar plexus within the psoas muscle with contribution from the L2, L3, and L4 lumbar nerves. It emerges on the lateral border of the psoas at around L5 level and descends between the psoas and the iliacus muscle, entering the femoral triangle deep to the inguinal ligament and the iliac fascia. The hip joint articular branches from the femoral nerve descend deep to the psoas muscle and tendon, and, at the level of the inguinal ligament, up to 14 articular branches can be seen traveling between the anterior inferior iliac spine and the iliopectineal eminence. The accessory obturator nerve, if present, originates in the lumbar plexus at the level of L2 to L5. It descends as a single branch deep to the medial aspect of the psoas and passes over the iliopectineal eminence where it enters the joint capsule. Both articular branches of the femoral and the accessory obturator nerves share common anatomical references, deep to the psoas tendon, between the anterior inferior iliac spine and the iliopectineal eminence, which can be visualized using ultrasound imaging. This is the basis for the pericapsular nerve group, or PENG block. Before we talk about the PENG block, we would like to examine the mechanism of how the 3-in-1 or fascia iliaca block works. Literature examining the local anesthetic spread following the 3-in-1 and the fascia iliaca block using MRI suggests that the spread will ascend at most to L5 level, where the femoral nerve emerges on the lateral side of the psoas. The spread extends laterally to cover the lateral femoral cutaneous nerve. However, the spread does not travel medially enough to involve the obturator nerve. At L5 level, the spread is not likely to reach the articular branches of the femoral nerve. Detailed examination of the lateral femoral cutaneous nerve block shows the sensory change commences from the greater trochanter onward on the lateral side. The analgesic effect of the fascia iliaca block, or 3-in-1 block, could more likely be associated with the relaxation of the quadriceps muscle by blockade of the femoral nerve. To begin, with the patient in the supine position, a low-frequency curve transducer is used and located initially along a transverse plane over the anterior inferior iliac spine to then be aligned with the iliopubic eminence of the pubic rami by rotating it about 45 degrees counterclockwise. In this view, the key structures to be identified are the iliopubic eminence, the anterior inferior iliac spine, and the psoas tendon. The femoral nervovascular bundle can be seen superficial to the psoas muscle. The 80mm needle is inserted in plane, in a lateral to medial direction toward the plane, deep to the psoas, between the iliopubic eminence and the anterior inferior iliac spine. Usually the volume is 20 milliliters. A successful injection can be confirmed by the spread of local anesthetic along this plane and a lift of the psoas tendon off the bone. The PENG block has thus been performed. The following are certain tricks to keep in mind while performing the block. If resistance to the injection is found, the following maneuvers can be performed. Adjust needle depth, as your needle tip can be subperiosteal. Withdrawing the needle slightly can change the injection resistance greatly. Alternatively, the needle does not puncture through the psoas fascia and further pushing is hindered by the pubic bone. In this case, performing a circular or rotating motion of the needle will facilitate piercing of the needle. Change the angle of entry. Change the injection site over the femoral head. Make sure the spread is just deep to the psoas, but superficial to the joint capsule and ligament. While the local anesthetic is being injected, lifting of the psoas muscle should be identified. If an inadequate distribution along the medial aspect is observed, the needle can be withdrawn and then directed medially, depositing a certain amount of local anesthetic at that level. This helps block the accessory obturator nerve more successfully, as its location is more medial. We hope you have found this brief explanation useful and that it will help towards the well-being of your patients. Please send your comments and questions to the following address.